because I'm covering the patients. Who's with me in the morning?
Me.
Yeah, okay.
Yeah.
Yeah, I'm taking cover. Any questions so far from the TGA and any questions? No.
No.
Cases with Sarah, right?
Yeah, it's always tricky, isn't it?
It is, yeah.
Especially when they're leaking and you don't know what's going on.
I have the number of 2 cases where there is a leak. I'll show it to you.
Okay.
But let me check here. Restless. There's nothing. Should I show you the? This is how it will look like on the cross section underneath. Not sure how to. The large get.
Yeah.
Okay. And we spoke about the coronary arteries. This is an MRI. It is without contrast. Is this 3D whole heart sequence? It depends on the respiration of the patient. So if the patient respiration is regular, homogeneous, then you will get very good images. But if it's kind of irregular respiration or the patient is claustrophobic, then usually you will get a very bad images quality. But because they are young patients, so usually we will try first with an MRI, and if not, then maybe CT. Yeah, and this is the tunnel. Maybe it's clear here now. Yeah.
Yeah.
So those are the tunnels or the buffers that they call it, and they are draining. So there is no communication between what's here and what's here, right?
Yeah.
That's why this is the blue color and the red color, right? And the pulmonary veins are not disconnected, so they still drain into this atrium.
Right. Yeah.
So they create as if they created this tunnel inside the atrial septum.
Yeah.
And this is sometimes the stenosis at the muffins and or the leak. Those are the 2 complications that we are looking at, plus the right ventricular function. All right, okay. I didn't know that I have this image. So this is the IVC, right?
Yeah.
And here is the atrium. Can you see the leak between?
Yeah.
So this is a communication, right? This is the pulmonary veins again, and this is the other side. And here's a muffin leak.
Yeah.
And you will see the jet more or less similar to an AC. If the shunt is significant and it's affecting the patient, then they have to undergo a resurgery, which is kind of a very difficult one because of the fibrosis now at the mediastinum, and they need to open this atrial sac and this synthetic or a patch or pericardium. That's not easy to resuture as well. So it's a very difficult complication to manage.
Yeah.
Do patients do better with the coins?
Do what?
Do they do better?
With the arterial switch?
Yeah.
Yeah, so far the outcomes, arterial switch is much better than the
Right.
atrial switch.
But it's technically
Because the left ventricle is this second ventricle, which is good, but on atrial switch, it's the right ventricle is the system.
Yeah.
It's kind of a palliative.
Yeah.
And I think the arterial switch is a long-term solution, and this atrial switch is not a long-term. Like it's just like a L levo. thing, and it will eventually fail.
The right ventricle.
Yes.
Yeah, we talked about this. Yeah, the LTGA. So if the images are clear or they are not clear. So I'm saying or I'm claiming that this is the right ventricle.
Yeah.
Is it true or is it wrong with what I'm saying?
Yeah, it seems true.
Why?
We have turbiculations and we have the tricuspid valve, which is more distal to the mitral valve.
Yeah.
Maybe that's
So this ventricle is going here.
Yeah.
So where is the aorta?
So the aorta is anterior, isn't it?
Anterior, right?
Yeah.
Is it on the left or is it the right side?
This is on the left side.
It's kind of difficult.
Yeah.
But again, it's the right ventricle on this side, so it's an L loop for this heart.
Yeah.
So the right ventricle is on the other side, right?
Yeah.
And we could prove it because the trabeculation and the moderating band and the tricuspid.
Yeah.
The key.
Yeah.
Sure.
Yeah, when you throw in some more trick questions.
Yeah, so the LTG. So we have VA and AV discordance. So either they would leave the patients without any surgery, and they keep following up and try to support the right ventricle as much as possible. Or the solution is to do double switch. So they would switch the arteries and they would switch the atria, which is kind of a heroic surgery. And I'm not sure how many centers they are doing it. There's very few that they would do it.
Yeah.
And I think so far the outcomes are still not well studied. Whether it's worth it to do it or because in some cases are being discovered at the age of 40 and 50. So we would say if you do a surgery at this time, then probably the ventricle will fail because of the surgery. So they would support and continue following those patients. So from cross-sectional imaging, again, it's just important to follow the systemic ventricle, which is the right ventricle in this or in those patients group. To give contrast or not to give contrast, usually at the base study, the first study, maybe we would give some contrast to whether there is any scars in the right ventricle or not. But during the follow-ups, unless something new happens, then we wouldn't need it. Just following up the systolic function and the volume of this ventricle and looking for any indicators that would say that this right ventricle started to go down or shut down. Right?
Yeah.
The surgeries are those we described. So the arterial switch and the atria switch. If they will do it with the same exact complications, we will look at outcomes.
Yeah.
The frequent presentation of those patients, palpitations, arrhythmia, having an echo, the echo would say it's a mesocardia, I cannot see any anatomy. That's the very common scenario that you would see with a CT or an MRI.
So the echo.
Patient having palpitations, arrhythmias, echo is not conclusive because of the mesocardia, so the sternum is in front of the heart. They cannot see anything from the sternum.
Yeah.
They cannot identify the anatomy, so they will send it to either CT or MRI.
Okay. So I have a question. When they do the LTGA, if they did the double operation atrial switch and arterial switch, how could the left atrium work as a left atrium after all these years of working as right?
The left ventricle.
I mean the left
Yeah,
ventricle.
that's why it's not.
Yeah.
It's very few cases where they would do, or they would see that there is a trained or a hypertrophied muscle on the left side.
Yeah. So they only may continue medical treatment for these patients.
Supportive medicine,
yeah.
In most of the cases,
Yeah.
But good question. So they could do something called training to the left ventricle.
Training.
Yeah, and sometimes they try to do it in the DTGA if discovered after the 2 or 3 months window.
Yeah.
So they will do something called pulmonary artery banding. So they will create a stenosis in the pulmonary artery. So when they create a stenosis in the pulmonary artery, so the ventricle that's facing the pulmonary artery will start seeing high pressure, right?
Those surgeons are very creative. Very curious. Having
That was
very
yeah.
small solutions. Yeah.
That's Yahoo from Egypt.
Really?
Yeah.
Yeah. Cool. Okay.
So he started training the right ventricle, training the systemic ventricle, which is the left ventricle, for some time until the left ventricle gets hypertrophied,
Yeah.
and then they would do the
switching.
switch.
Yeah. Big genius.
Yeah, and we talked about what we are going to see on those. Yeah. Should we continue, or because it's almost 10?
We can also get angry with
Alright,
the
okay, so we could stop here.
Okay. See me talk.
How will you stop the recording?
I think from the
That's still
the next.
Yeah.
The next icon is.
this one.
Oh, I don't know.
Well, maybe if we said leave, then
Yeah.
stop. Yeah.
Yeah, stop.
Let's stop presenting. Yeah.